Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is CMS enforcement to provider risk, the downstream impact of RADV audits. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Valerie Rock, Bob Pikowski, and Christy Evans.
Thank you, Jen. Thank you all for joining us today. We appreciate the opportunity to serve you through these educational offerings and to come alongside you to learn the latest compliance trends and that impact our clients. So today we want to especially focus on providers who render care to Medicare Advantage beneficiaries to help you gain an understanding of the MA reimbursement flow and how you can partner with MA plans for compliance and reporting. Now, we know the relationship between providers and MA plans can be somewhat complicated. So we want to share with you today our experience related to this area and to help you with your perspective on this complicated relationship and how you as providers can mitigate your risk. So I'm Valerie Rock. I'm a principal with PYA. I've been with the firm for 22 years and I'm out of the Atlanta office. I oversee all of our revenue integrity services, which include, from this perspective, both Medicare Advantage plans, RADV audits in the sense of the mock audits that you might do ahead of an actual RADV audit versus large provider practice that may have risk adjustment as a large component of their payers. So we can assist those types of providers with their routine auditing to ensure those codes are accurate as well. And again, in that partnership with the MA plans as that reporting is communicated up. So Christy, you want to share again?
Sure. Christy Evans. I'm a principal here with Valerie in our revenue integrity. I have probably over 25 years of experience in multiple facets, from the provider practice to the hospital side and also from the consulting perspective. So it's a little unique being able to see it from a 360 view. Bob?
Thanks, Christy, and thanks, Valerie. Good morning to our audience. I'm Bob Paskowski. I'm a consulting principal. I lead our managed care service line for the last 10 years. But before I joined PYA, I spent over 25 years on the health plan side, most recently with a Medicare Advantage plan here locally in Ohio, where I ran that plan. Also had the experience of going through a risk adjustment data validation audit, which we're going to be talking about today. And most of my time in my career has been with provider sponsor plans. So albeit I was working for a health plan, I also worked for a provider organization that sponsored the health plan. So we'll go ahead and get started here this morning. Just want to talk first about the learning objectives. And again, thinking from this vein, we're thinking of through the provider's lens as we put our content together. So the first objective we want to talk about is the Medicare Advantage flow of funds. We want the audience to understand how Medicare Advantage payments flow from CMS down to the MA plans, then eventually to the network providers. Learning objective 2 is around the risk adjustment fundamentals and oversight. Here we'll discuss the fundamentals of how Medicare Advantage risk adjustment works and some of the content around how the RADV audits are conducted. Learning objective 3 is what's the role of the provider, identify the role of the provider in compliance, clinical documentation, and operational support. And then finally, provider strategies, evaluating how providers can assess, mitigate, and respond to the risk in connection with their contractual obligations, their own internal risk adjustments, programs, auditing and monitoring, and payer alignment. So that's what we're going to talk about this morning. Let's start first with how the flow of funds work in the Medicare Advantage. We want to first start with just a simple definition of what a Medicare Advantage plan is. So it's an insurance plan offered by private insurance companies to Medicare beneficiaries. They must provide the same benefits as original Medicare. includes both Medicare Part A and B. And they also offer additional benefits like vision, hearing, dental, etc., and a little bit of pharmacy as well. But the beneficiaries elect to join an MA plan when they become eligible as a beneficiary, or they can stay with traditional Medicare. There's typically a shopping season, as they call it, for about 52 days from October 15th each year through December 7th, where all those beneficiaries are making their elections. Do I stay with my current plan? Do I fall back to traditional Medicare Advantage? So there's a lot of activity there in those 52 shopping days. And the beneficiary, again, this last statement around Medicare services are covered through the plan, but they're also going to sign up if they decide to go with an MA plan. They're going to select a network, and that's part of their decision process of which plan to pick. But it will depend on perhaps their providers in their network, and a lot of times part of that decision is whether that plan also covers Part D or prescription drug coverage. So that's our definition. So let's just talk a little bit about how how we view the funding of the program, the Medicare program, and then how that permeates down to the provider payments. So the traditional funding is historically, before MA came into play, CMS took all that risk. They received dollars through the Medicare Trust Fund. There may be collecting some Part B premiums from beneficiaries. That's the traditional um, program as it was set up, and that CMS took that risk. Over time, and it's become very, very popular now, where CMS cedes that risk down to a Medicare Advantage plan who requests a contract from CMS to join and submit a bid and participate in the Medicare program. But once that happens, Medicare cedes its risk to this MA plan, and then the MA plan is paid from CMS a capitated amount adjusted for risk, um, a risk score, which we'll talk a little bit more in detail for each beneficiary. So again, that's how the funding choices kind of set up. Either you can stay in traditional or move into the MA plan, and the risk changes. On the provider side, if that beneficiary stays with traditional Medicare, providers are paid like they've been historically from CMS based on the procedures performed on a fee-for-service basis. Under the MA program, if that beneficiary has an MA program, there is usually a contract that oversees the relationship between the provider and the payer, and that's how those claims are paid. Typically, you'll see a lot of those are based on procedures performed, but there are some opportunities for additional payments through capitation and other risk adjustment um, uh, value-based payments. Okay, so now we've set up the program. Now we're going to look individually, a little more detail on how the payment moves from a MA plan, from CMS down to the MA plan. So if you're the MA plan, you basically have two revenue streams. You get a payment from CMS, and then you can also receive dollars through the enrollee through their premiums. Let's talk briefly about the enrollee side. That's pretty simple. So when they're selecting a plan, sometimes it's a $0 premium. So there is no revenue coming back from the enrollee to the MA plan, or there's some fixed premium, like we're used to paying a small premium that would go to the MA plan to support the program. So and I would say probably 95% of the dollars are coming from CMS in this equation. Very small amounts come from the enrollee. But that 95% coming from CMS is based on an annual bid. And we'll talk a little bit about that more in more detail. But it's also a fixed monthly amount from CMS based on that bid and based on the enrollee's health status. So if we think of approximately $800 a month comes in from CMS to support that revenue and to pay those claims for each beneficiary. And again, that $800 in our example here is based on the geographical benchmarks, the MA plan star rating, and the enrollee's risk adjustment factor, or RAF score, which we'll get into a little more detail here in a minute. Okay. So that's how the money came in. Now, how does the money get dispersed to the providers? How do the MA plans pay for these medical services? Again, typically, as I shared earlier, there's a contract between that provider and that MA plan that for every MA patient or beneficiary that is seen, here's how we're going to pay you. So it's really dictated based on that individual contract between the payer and the provider. Typically, we'll see those contracts very unique to just Medicare Advantage. Sometimes we'll see those an amendment to let's say, a commercial contract, but it's usually pretty definitive how they're going to pay the providers for a Medicare beneficiary. There's three different ways they can be paid. One of which is fee for service, capitation, or other value-based payments. Again, the lion's share of the dollars that we see in our practice typically on fee for service. And for some of the larger providers, they may take some risk. They may ask for dollars based on shared savings or their quality metrics that they're helping the MA plan with their star ratings to drive beyond the fee for service dollars, earn some additional dollars for both quality and shared savings. Just want to kind of discuss here briefly the difference between a risk adjustment method and a fee for service method. We talked a little bit earlier about fee for service. It's based on the actual procedures that come in on the claim, and that's what gets paid for. But when CMS goes to pay an MA plan based on risk adjustment, it's not based on an individual claim. It's a buildup of a profile for each of those patients or beneficiaries based on diagnosis codes, their health conditions that are currently being managed, and again, based also on their both age and gender. That builds up that RAF score, as we talked earlier, the risk adjustment factor score. That's how CMS will pay an MA plan, which is different than fee for service. I just want to talk about this briefly, and we talked internally about should we put this in, should we not put it in. I think it's important that if you sit in the shoes of the MA plan, here we are, we're in 2026 now. They are still building the risk profile for a 2025 patient. It is not over yet. And so that I'm kind of leaning toward the right side of the page here about retrospective risk adjustment. You're still building the profile, even though 2025 is now ended, there are still claims that are still flowing through. And in a retrospective program typically works, let's just say we have a patient who in the past has had a heart condition. They've received all the claims for 2025. And Jane Doe's claim does not have any cardiology conditions reported. So you're thinking, well, why would that happen? So what typically starts to happen is the MA plan will start to send out notices to your cardiology providers who may have treated Jane Doe in the past. Hey, can you look through your medical records in 2025 to see if you're treating Jane for a heart condition? If that gets presented, then they still have time. I think it's through, August of 2026. They can still finish that profile for a 2025 patient. So that's the retrospective program. So it's always kind of playing in arrears and trying to catch up as they kind of come to the end of this cycle. Or to the left side, we talk about prospective. So today, Jane Doe has a heart condition. Let's get that in 2026's medical record. Let's get it sent over the MA plan. So we're already treating that patient now in 2026. Again, the purpose of that is more for care management and being ahead of the case and trying to treat Jane for that condition now as the patient presents to the providers. So I just want to distinguish between those two. And then I'm going to turn it over here to Christy and Valerie to talk a little
Mhm.
about the compliance differences between traditional Medicare and MA. Valerie?
Thank you, Bob. And I may have a question for you as well, because I think as we navigate who, like if you're a practice, a provider practice, there may be other providers that are out there that are impacting the claims related to the beneficiary you're serving. So, just because you are a provider submitting claims, it doesn't mean you're the only one serving that patient. And so you're also, you have multiple providers, multiple entities then submitting claims up to the payer, but the CMS is looking at that payer from a beneficiary level when it's, doing auditing and things like that. So what from your perspective, how does that complicate things maybe from the payer perspective?
So great question. And sometimes you can look historically. So if you've had, using Jane Doe as our sample here, beneficiary, if you've had Jane in your program for years, you can look back for that cardiology condition and see who the providers have been who've been submitting claims around that have triggered that condition. So that always gives you a clue to go to backwards. But you're right, it could come from anybody who is treating that condition, that supports that condition, that you can submit to CMS. It doesn't need to
Right.
be just one particular provider.
Right. So when we talk about obligation, right, when we talk about False Claims Act, even 60-day rule and things of that nature, like who is responsible for the claim that is submitted? And in traditional fee-for-service scenario in Medicare, the provider is submitting the claim to the governmental payer, and therefore the False Claims Act obligation is tied to between the CMS and provider. So the provider is on the hook for the FCA issue. In a Medicare Advantage plan scenario, Medicare Advantage plans are submitting the data that supports the payment from CMS. So when the plan is submitting that information over to CMS, any type of information that flows that way, it ties back to the Medicare Advantage plan, not to the provider, because the provider is not the one directly submitting claims. But there is some activity in regards to court cases, et cetera, where the courts in certain circuits have been differently resulting in regards to the relationship with the provider and the MA plan. So in the provider's scenario, if the provider had submitted a correct claim, then the MA plan wouldn't have been harmed. So, but for the claim that the provider submitted, now we have a false claim. So there's been some disagreements within the courts whether the physicians are on the hook from a False Claims Act perspective or not. But it is a risk, right? We have to be careful that we're not submitting incorrect claims. And of course, there's a legal obligation, contractual obligation to submit correct claims. So there is a potential liability all the way up to the False Claims Act liability if you submit false claims. But as you were talking through, Bob, it's most likely going to be those providers that are targeting, higher codes or whatever. And it's kind of an egregious scenario where you have, like a code that's just way out of range and they get targeted for an audit. And then that kind of focus comes into play. Would you agree?
Yes, I would agree. And we're going to talk a little bit more about some of the contractual obligations. Are some of the MA payers actually going to hold some of
Mhm.
these providers accountable that for, each claim that you submit, you have to have support,
Mhm.
because they're going on the assumption that those are all substantiated and I can send those on to CMS. So
Mhm.
yeah, I would agree.
So with the next component, we want to make sure it's clear that diagnoses are the ones that are driving reimbursement related to the MA plans. So when a physician or a hospital is submitting claims relevant to a provider's service for a Medicare Advantage patient beneficiary, then those diagnoses are saying this is the complexity of the service. This is the complexity of this patient, and therefore we're going to increase the score. We're going to talk about that a little bit more here in the next few slides. But that diagnosis is the center point. So when we're looking at how things are captured, one of the risks that has come into play is how these health risk assessments have been captured by either the payer or the provider. And in some cases, there have been payers that have captured health risk assessments with nurses on at patients' homes or via kind of a telehealth visit. And all of that is capturing diagnoses maybe throughout the patient, but then ongoing throughout the year, there's no indication that the physicians that were overseeing the patient's care were actually managing those diagnoses. And then they're coming into question, and they're questioning whether the HRA, that health risk assessment, is really supporting the diagnosis that should be supported relevant to payment. So those are the types of things that we see as a risk to Medicare Advantage reimbursement. So Bob, you want to cover, go ahead.
Maybe if we just go back one slide here. I also want to mention in this last bullet, we talk about litigation and government interest. You probably read where, alleged that they're being overpaid, et cetera. The other allegation is around if you send me a chart and I'm looking through the chart and also see that, hey, here's an addition, but also notice something that, boy, this should be deleted. So one of the things that, again, has been alleged is that you're only looking for adds to those conditions. But when you're in there looking at charts, you need to look through the whole lens of, hey, this doesn't look like it supports, X or Y condition. We need to remove that as well. So that was part of the allegations that are coming up during these RADV audits.
Right. And that kind of ties back in, we'll talk about this several times, I think, but ties back into, you may not have documentation support for that specific instance under that provider NPI, for example. But if you go to another provider, maybe there is support, for that diagnosis. So we want to make sure that we're, providing as much comprehensive documentation that we can, from each entity's perspective. But there are other entities that may impact that total risk score.
Correct. Let's move on. So let's go to learning objective 2 and talk about risk adjustment fundamentals and oversight. We've hit on this a little bit, but think of risk adjustment as really a prospective look at what claims will look like into the future. So it's really, we're calling it here an actuarial tool. It's trying to predict based on prior conditions, prior claims, your age and gender, what you're going to consume in care in the future. And that's how CMS has built this risk adjustment methodology. And you can see this little picture down here of what are the inputs to building that profile. Again, demographic data, which would be both age and gender, diagnosis data based on prior claims that have been submitted, and utilization, which providers you're going to, et cetera, to build up this profile. And to the right side of that, there's a algorithm that CMS goes through and says, okay, Jane Doe, based on all that information, is a 1.1 risk adjustment factor score, or RAF score. And if you think of all the Medicare beneficiaries in the country, if you put them all on a sort of a normal distribution, CMS is trying to hit the 1.0 sort of that center point. So to the extent you move to the right of that curve, those are the higher end, higher risk adjusted beneficiaries. I've seen as high as 27, those kind of scores. So you're getting quite a bit of funding because those are a lot of comorbid conditions, versus the more younger aging in at age 65, maybe below 1, more like a 0.6. So as you kind of put that over that normal distribution, each member gets their own individual RAF score. So if you've got 60,000 members, everyone has a unique score, and that's how CMS pays pays for that. And again, this little picture down here, but so that's comparing it to the overall large group of, if you put all the beneficiaries in place, we're trying to move toward, 1.0 as an average, but it can vary based on each patient's profile. A little detail, and so currently, MA plans are building their bids right now for 2027. They'll have to submit that, I believe, by June 1st. So they're looking through all their information right now on, the benchmark data. They're going through the bid process. They're looking at benefit designs, all those things, and they'll submit that bid in June. And then that again that's based on a benchmark based on geography of where those beneficiaries are. It's usually done by county. So if you think of every state in the country, every county has their own benchmark rate. So that builds the base. And then as you move on to the right side, okay, if that's my base, now I've got to look at the profile of every Medicare Advantage beneficiary and compute a RAF score, risk adjustment factor. And that's again based on the demographics, including age and gender, their risk profile, claims in the past, et cetera. So that Jane Doe is a 1.1 built on all that information, and that creates her risk score for 2026. And then the MA plans are paid based on Jane's score of 1.1. I think it's important for the audience to understand that the importance of looking at risk adjustment, because if there is something additionally found on Jane and no condition, that 1.1 could go to 1.2. And so you think of that, that's a sizable increase in their premiums every time there are new conditions identified and supported. So that's the importance of how sensitive these scores are, and the importance around and the attention it's getting nationally of how we build these profiles. This is just for you all to see, and we'll talk a little more. And CMS came out last year saying we're way behind. They have not done risk adjustment data validation audits. They were behind last year. They were trying to catch up all the way to 2018. I think they're through 2018. They're through most of 2019. Here's the schedule for the next several years. I think this may even been a little outdated as well, but they're trying to catch up, and they're auditing every MA plan for all those years. They were backlogged from 2018 through 2024, so they're trying to do this very, very quickly. We bring that up again if we're talking to our provider clients. You're getting a lot of requests for medical records, because if they pick a Jane Doe as one of their samples, they have so many months to go ahead and grab the medical records substantiation to support that. If Jane Doe is a 1.2, I've got to come up with all the conditions that support her in from a medical record and then upload those. So this is where it's put a lot of, I know there's emphasis on the MA plans to get caught up, but really they're relying quite a bit on their provider networks to provide that documentation. I think we're going to go ahead and transition this over to Valerie and Christy. Now we're talking about, okay, now we're caught up. Now we're going to, all these notices have come out in 2025 and 26 to try to catch up and go through a pretty rigorous process to do that. So I'll turn over to Valerie.
Thank you, Bob. Yeah, I think the key here is that everything's still moving, even if it's slower than they're planning. So they're trying to implement things like AI tools and other like increase in their workforce in order to accomplish these audits. They have said that they're going to make sure that anything that they're deeming as incorrect will be reviewed by a human, but they are trying to implement tools to increase their efficiency. But they're, like Bob said, at the 2020 payment year as of the beginning of this year. So they're still working through that, and they're going to kind of front load some of the later years like 2024 early on in the process. Christy, anything to add to this slide here? You're on mute. Sorry.
Sorry about that. So everything they're trying to do to get everything caught up is really signaling that they're not stopping the enforcement. These audits and these reviews are going to continue despite the delays. So I just think that's a big point for everyone to remember.
Right. And there was some information that came out or in the final rule from the Medicare Advantage final rule back in 2023 that was refuted in a court case by Humana. And because of the specifics regarding extrapolation and an application of, or a lack of application of, a fee for service negative adjustment to potential overpayments, that component was vacated by the courts because of the fact that they were not included in the proposal for comment. So because they didn't allow the payers to comment on those components, they vacated those pieces. But we're seeing in 2026 and even in 2027 that we're moving forward with components of extrapolation, and CMS is saying that they're designing the audits in order to still comply with the earlier requirements related to extrapolation that were in final rules prior to that 2023 communication. So we do anticipate some level of extrapolation in the future, but they're still kind of trying to decide how they're going to do this. So otherwise, the payer would be submitting a sample. So CMS selects a sample of the claims of the MA payer's claims. That sample from like 35 claims to 200 claims are then sought after by the practices. So the physicians or hospitals that actually have this documentation are then requested of these records. So you may have one record requested or two records requested out of the 200 that were requested for that beneficiary and the beneficiaries that are a part of that sample. So it's not that it's not as likely that you're going to get a large grouping of requests from one payer, but you may get several different payers saying, I need these records. So that will be kind of how you see that come across. And they may have a portal for you to upload that documentation. They'll have a checklist for you to follow. So making sure that you're really following that checklist and getting what they're requesting, to include not just submitting the entire record for that year, that plan year, but to really make sure that you're submitting support for the specific diagnoses that you submitted. For example, we've seen some payers say, well, we don't want to see more than 2 records per diagnosis that you've supported. So you're really trying to get your best documentation to support those diagnoses. Anything to add there, Christy? You're on mute, sorry.
So Bob, how does this factor in with the different payer contracts?
Correct. And you can see the last bullet here about, the potential is the key word here for provider clawbacks. And Valerie made the point earlier to say, if I'm one of many providers in that network and you're leaning on me as the only provider that can support a particular condition, I think that's a little harsh to me. But again, it's important to look at your language in there, either under indemnification or under audits, because typically in the contracts, the payers have the right to audit what you've submitted. So that's kind of what they're doing here. They're asking for that support. So you need to look in that particular part of the report of the contract to see, is there any remuneration or clawback, any kind of penalty if I can't substantiate that. I don't see a lot of them in there, but I think they're writing some very large checks here back to the OIG and CMS for these paybacks. There probably will be a time where they may start to hold some of the providers accountable in some fashion. So just for this provider group to kind of be aware of that.
Thank you.
Perfect. Thanks, Bob. So let's talk about the role of the providers here. So what do we need to ask from the providers? Everything starts and stops from the provider documentation, right? So that compliance responsibility really starts with the provider with the documentation of the patient's visit. And once the provider submits that claim for payment, then that data really becomes federal payment data. So it should really be looked at as regulated financial reporting, not just necessarily clinical preference as to what needs to be in that record. So there's that shared risk environment because you've got the provider documentation that really just relies on everything. So that documentation should show a complete and concise picture of the patient's condition. And so that excellent best practice documentation is really going to show the thought process of these providers when they are treating their patients. So when it comes to RADV reviews and audits, there are administrative guidelines that the records are held to see if that documentation is going to be allowed to support a code reported on that particular day. So these administrative guidelines is it a face-to-face visit or those that are approved for telehealth? There are only particular appropriate provider types. I mean, you've got your MD, your DO, your normal mid-level APP, nurse practitioners. However, there are inappropriate provider types, social workers, RNs, LPNs, medical assistants. Those are not going to be appropriate provider types of documentation. The service must also take place in an appropriate location. So provider's office, the inpatient hospital, certain outpatient facilities. But then we do have those that are inappropriate locations. So labs, imaging, those types of visits are not eligible for HCC reporting from those particular visits. Because again, if you think about it, that is not a face-to-face visit with the provider. Some others that are not eligible for HCC reporting are hospice, skilled nursing, dialysis centers, and then some freestanding ASC centers. The last big piece of the administrative guidelines is that signature. So we're always looking for the provider's signature along with the credentials and the date. So, we think of a lot of this as just key parts of the medical record that we're always looking for. But just one thing to know is when these RADV audits are happening and a visit comes across that they're looking at, they are looking for these particular things before they even go into what the documentation says. If it's not signed, doesn't matter. They're not going to look at what that documentation is. So you've got to have these administrative guidelines. And, there are a lot of denials that are specifically for these administrative guidelines. So you guys talked before about the HRA documentation and the coding guidance. So this documentation, the HRA, is a requirement for the Medicare wellness visits. So it's supposed to include the chronic conditions that affect the management of the patient. And we know that the chronic conditions can only be coded if they are documented, but that documentation has to tie in to how the chronic condition impacts the patient treatment at that particular visit. So it needs to link in to all the other conditions and how it affects how everything is being treated. So you've got the cases where a patient comes in and it's just for a straightforward complaint, something pretty simple. But then the patient's underlying chronic conditions are very likely to influence the medical decision-making of how that provider is going to treat that patient for that straightforward, simple complaint. And the documentation of all that in the record really goes to show that thought process, the overall clinical picture. So all of these things always need to tie back into each other. And as we know, each data service must stand on its own. So we can't have a visit from last week and pull information from a visit 3 months ago. Each visit has to stay on its own. So ICD-10 documentation and coding guidance. We know that there's problems in the medical record that we see the problem list. The problem lists are always a problem. A lot of times those are pulled through our EMR templates, and there's not a lot of internal operations process to be able to keep that problem list up to date. So you tend to have acute conditions in the problem list that's no longer relevant. Conditions that were previously treated, I've seen in records before where patient has tonsillitis, but you get further on down into the record and they had a tonsillectomy 12 years ago. Okay, I don't think they still have tonsillitis. And, we always have the high risk diagnosis when it comes to cancers, acute MIs, acute CVAs. It's likely to see that stuff in the problem list, but you really have to look at the documentation to see if it's really a condition that's still acute or if it's a historical condition. So the ICD-10 coding impact to that RAF score, again, everything goes back to the documentation, the completeness and the specificity of that provider documentation. So if the provider, all it says is diabetes, but we see maybe in previous visits, the patient had some complications reported, we have to rely on that one visit for that particular data service. Again, you can't go back, and you've got to have the specificity in that particular note. And this is really where it comes into play of, using the example of diabetes. You've got the complications, and most diabetic patients that have a complication are likely to have multiple. And so when the documentation supports those multiple complications, you want to make sure that you do report all of those with the ICD-10 coding, because it does show the clinical picture of the patient, because you don't want to just show that you're reporting the highest risk adjusted score. You really need to make sure that you're coding everything that is there for the patient's visit.
And Christy, with the documentation for a date of service, you may have a date of service like under documented, for example, and you may not be supporting the diagnosis that day. But because this is based on a plan year, if you have a beneficiary record requested, you're going to be asked for the entire year. So as long as you've reported it correctly for at least one of those claims, then you're supporting the diagnosis for that patient, for example. So thoughts on that?
Yeah, I mean, a lot of times you'll see providers go, well, if I only have to document it once, why do I even need to bother throughout the rest of the year? And, they need to bother because it does support the full picture of the patient, and you don't want just snapshots of a piece in time that doesn't necessarily show the whole picture. All right, so CMS changed to a different model of the risk adjustment scoring over the past couple of payment years. They did some overlap between V24 and V28. So V28, this is CMS's response to all of the coding variability and perceived overreach. A lot of these codes were removed from V24 to V28 because it was determined that the conditions or the coding was very subjective or gave inconsistent diagnostic patterns. So a lot of codes were removed where they determined that the condition really didn't have a long-term effect on the clinical picture of the patient. And so they did not have that clinical significance that they thought it would. So they've made some adjustments in that particular area. So, if a condition is difficult to validate consistently with those long-term cost implications, then that's really where they made some changes. So the HCC requirements, we talked a little bit about already, the administrative. One of the things we really need to make sure too is that the patient's name and the date of service has to be on all pages. So if you've got an office note and just say perhaps it's handwritten, that has to be on every page that's going to be used to support the diagnoses that were reported. Again, face-to-face visit must be documented in the medical record. And again, the provider signature is absolute. We all hear the helpful acronym MEAT, M-E-A-T, when it comes to documentation to support the coding from the documentation and record. So it's, M is monitor, ordering labs, diagnostic tests. You've got evaluating, assessing or addressing, or treatment. So when you're looking at this from a coding and a documentation perspective, that condition doesn't have to meet all of these. You're not looking for all of these different pieces. You're looking for one of these. So if the provider orders labs, if the provider simply stated the condition as stable or improving, again, you just have to meet one of those elements. We use MEAT all the time. But do remember that acronym is not an official coding guideline. This is something to kind of help get your perspective in what's going on that particular patient record. So how does all of this interact and interface with your E&M guidelines? So, is it a problem that's affecting the medical decision-making of that particular data service, or is it something that really the provider is not, the medical decision making is not really affected by that particular condition? So this is where you have the difference between your CMS guidelines, your CPT, E&M guidelines. So one of these things that it's kind of hard to get in your head sometimes, because we're always, referring to the different guidelines and what meets what. But if you think about it, a condition can be clinically managed and noted and indicated within the record, but still not significant enough to alter that E&M complexity. So you may have diagnoses for, patients coming in today, they've got, let's just say, an ingrown toenail. So patient is diabetic and has some other things going on. So you may have things in the documentation that is supported from an HCC basis that does not affect the E&M, and you're not using that as a particular problem addressed to select that E&M level.
And I think, Christy, that this comes into play when you're looking at it from the provider perspective, because as the provider being paid on a fee-for-service basis by the MA plan, then you're being paid based on that E&M, right? So now I've got payment based on that E&M. I've identified maybe some risk or some issues with documentation for my HCCs or my diagnosis codes. How does that then impact my E&M? And it's not a one-to-one. It's not an absolute and direct impact. So you'd have to analyze it separately. The E&M impact and the diagnosis impact would be a different quantification.
Exactly. So, what matters for the HCC is the clinical relevance and the documentation, not necessarily that E&M billing impact. CMS does not drive that documentation requirement up to the same level as what you have to have for it to support your E&M level.
Right.
So some common errors that we see a lot we already kind of touched on some of these on the problem list, but the history of condition that's no longer there, cancers, acute MI, you're going through a chart and you're auditing and you see acute MI on a regular office patient visit. That should automatically be a red flag, because it's very unlikely, unless that patient had an MI in the office that day, they sent the patient to the hospital. It's very rare that you would actually have an acute MI coded on a follow-up office visit. So those kind of things is, you see low-hanging fruit. Very easy to look at that type of thing when it comes from an audit and a review. With regards to the specificity, if you've got the CKD and let's just say it's not specified to a particular level. So CKD unspecified, the N18.6 does not risk adjust. But if we have that extra piece of documentation to give the stage of the CKD, then your stages 3B and your stage 4 does risk adjust. So this is where the specificity in the physician documentation really comes into play. So again, some other common issues that we can see. The provider wants to assign only that first diagnosis to the visit. The reason they came in. And they really need to add in all of the chronic conditions that were mentioned, addressed, that really came into the medical decision-making process for that particular patient. Anything to add, Valerie?
Nope, I think you've got it.
I'll just make one point. One thing you said, Christy, about, when that the first presentation of that patient and, I've already documented, I don't need to worry about it. One comment I make is, that still is some reviewer is going to look at that first documentation. They're going to make a subjective decision whether it does or does not pass. So I would just, again, recommend the more, documentation, the better, because one may pass and maybe that second one, the first one may fail, but the second one may pass. So it would be important to get them all documented throughout the year. Just be one comment I'd add.
Yeah, and one way I've kind of always thought about that is, say in the inpatient world, you've got CCs and MCCs affecting that DRG that's assigned. You always want to make sure that you've got more than one CC or MCC to be able to support the record if for some reason one was found not to be supported. So I just kind of have that correlation over to the provider documentation when it comes to this piece of it as well.
So we'll talk about, as we close out, in regards to the provider strategies. So MA plans have had several different changes over the past few years in final rule from CMS. Of course, they have to cover all the services that CMS covers at a minimum, but CMS has also laid on kind of a factor here where they also have to follow LCDs. So local coverage determinations, national coverage determinations. If Medicare says there's a certain level of coverage that we're going to use, then they have to follow that. And if they're going to do something in regards to coverage on their own, then they have to base that in, peer-reviewed journaling and evidence-based medicine, and making sure that they're tying that and then publishing that. So you should be able to find those policies and identify what the coverage requirements are for your MA plans. And outside of that, then you would follow normal Medicare policy. That is kind of a departure from the past where we kind of saw the Medicare Advantage plans as really commercial plans. So we were just thinking of them from a commercial perspective as opposed to a CMS perspective. They've also standardized the review process for their audit, so you can go through an appeal process, or the plan, the Medicare Advantage plan will go through an appeal process. And at the end, that they have to get all the way through to the denial to get to start that appeals process. So you may receive additional documentation requests after an original request if they feel like maybe there's additional documentation in here that you haven't submitted to us that would pass muster. So be watching for that and responsive to that, because those requests could be just a 15-day turnaround. So you want to make sure you're being really mindful of what that request may be. And then, of course, as Christy talked about, there's the V24 to V28 changes as well. We do see actual extrapolations happening from the OIG. So just because the RADV audits are doing one thing, it doesn't necessarily mean the OIG is not active. So the OIG is also doing audits and extrapolating those issues, especially if they feel like there's maybe some fraud involved and things like that. So you'll see in this activity that that they're being focused, they're making sure that they're looking for where the risk is and addressing that risk. Another outcome that has come from the OIG is the OIG, of course, created the compliance guidance, the general compliance guidance, but the industry segment specific compliance guidance for Medicare Advantage has come out this year. So you want to make sure you know what that is, even though it's directed to the MA plans. So when you look at that, you can kind of glean what you would do as a provider to be compliant with the payer, and ensuring your diagnosis accuracy, monitoring your own data, doing your own data analytics on the top diagnosis codes that are at risk. CMS, you'll see in the different audits that they're doing, that in the RADV audits that you'll see that, and the OIG audits, which risk diagnoses are out there and what is relevant to you, and how can you monitor those diagnoses as well. If you have a vendor or a system that you're utilizing internally to monitor and manage your risk adjustment, then you want to make sure that you're actually monitoring those vendors or processes or systems as well. Don't assume that they're accurate. There's a lot of AI tools out there. There's a lot of other vendors, et cetera, that are going to assist you in this process in capturing the diagnoses and anticipating the diagnoses that need to be managed. But you want to do that in a proper way, in a way that does not lead the physician, but that does produce the right results ultimately based on the patient's condition. Maintaining your own compliance program, having a compliance program and following that, letting that be a truly effective compliance program shows that you're doing your diligence. Having an active auditing process will also show that as well, because we do anticipate that increased MA process as well. Let's see. So this was a slide. Apologize, I didn't move that, advance that to you, but this is the guidance that we recommend you think through from the lens of that industry segment guidance. Lastly, if you think through the risk from an MA perspective over into the risk from your perspective, if the provider is going to receive variability from diagnosis codes that are, the MA plan is receiving diagnoses from the provider, then that data integrity is going to be compromised at the payer level. If there's unsupported diagnoses that are submitted to the payer, then that's going to create overpayments for them and recoupments, which would likely have downstream risk, though not direct downstream risk. Again, if you're sending one or two claims and they're wrong, that doesn't necessarily mean you're going to have immediate response on that. But if there's an indication that there's a high number of diagnoses that may be high risk coming out of your practice, you may be a focus area for that payer to audit you, right? So watch out for education. You may receive education from a payer that creates a change in your diagnosis coding, or you may receive education from another association, et cetera, and it changes diagnosis coding. Ensure that diagnosis is accurate and that it is truly appropriate based on clinical presentation and diagnosis coding requirements. We've seen situations where those diagnoses are actually incorrect, and the payer may even come back and say, oh, well, don't use that code anymore, but now you have all of these diagnoses out there that with the wrong code. So you want to be very mindful and very careful with any changes in coding. Ensuring that you're doing your own validation audits of your coding and monitoring that so that that is detected on your end, because otherwise the payer may be on the hook for that as well. And then member switching, because you may have, as Bob said, there may be changes from the members. They're moving from plan to plan, then that creates kind of a lower monitoring, if you will, of the patient. But you want to make sure that you're still providing the right diagnosis codes relevant to those patients, and you're consistent with that so that the patient is covered for all of the services that they need to have, because that could have downstream risk to you. And usually what we see is if there's an audit and there's inaccuracies and high inaccuracies over time, that the contract will be at risk. That's usually the first thing. The actual recoupment on certain claims would be very difficult to substantiate, especially if you have multiple providers seeing that patient, because if the other provider is actually supporting the diagnosis that you were not, then that other provider created the correct claim that ultimately went to Medicare. And so there was no harm to Medicare, the Medicare Advantage plan. So we want to determine really where our risk is and how we address that. But if you find that you have, a series of claims or a number of claims that are outside of what they should be from a coding perspective, then you want to work through the analysis of what is your obligation as a practice, what are the contracts related to your practice that you would need to address and follow in order to be in compliance with that contract. And then are there any direct financial obligations that could be actually in your E&M codes as opposed to your diagnosis codes because you're paid on a fee-for-service basis. So that analysis gets more and more complicated as you have more complexity across providers and how that works. So we wanted to walk through this with you to show you that there's a lot of complexity in the way the payments flow, such that you would have an obligation ultimately. And it's so complicated that we often find that there's not a whole lot you can do. So communicating with your payer, determining if direct communication with your payer is appropriate, or if you're going to do, review and educate and address those direct claims that were reviewed and resubmit the diagnoses that are appropriate to that MA plan for any of the codes that you actually review. So anything you review, we recommend adjusting that and then determining how you address retrospective audits. Just like we said, we're looking at 2019, 2020, all of those older prior, years that we're looking at from those payment years, those could be implicated as well. So we want to be mindful of our actual obligation, which is a legal analysis. And we recommend, working through that with your inside and outside counsel to ensure that. Any closing thoughts, Christy and Bob?
Now, the only thing I would add is that for everyone to keep in mind that the meter starts again every January 1. So whatever happened in 2025, it starts back at zero when you hit January 1 of 26. So you got to rebuild that profile. So what you substantiate in 25 may get the same request, in a subsequent year.
We'll turn it over to Jen.
All right. Thanks to our presenters. Valerie, Christy, and Bob. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.